Welcome to episode 11 of the MBT podcast. In the previous episode, we discussed session 10, titled Anxiety Attachment and Mentalizing. In this episode, we will continue with session 11. So imagine this. You just got a massive promotion. You are, packing up your apartment to move to this vibrant new city for a job you have wanted for years.
Right. A dream scenario for most people.
Exactly. Logically, you should be absolutely thrilled. You're advancing, you're succeeding, you're doing all the things you set out to do. So why does your brain's oldest neurological hardware suddenly just start firing off these massive alarm bells, interpreting this incredibly positive life transition as this terrifying existential threat?
Yeah, it is honestly one of the most counterintuitive quirks of human psychology because, we are conditioned by society to think of depression and profound sadness as reactions to very obvious visible tragedies. But the clinical data, especially what we're looking at today, tells a very different story about what our brains actually consider to be a crisis.
And that's exactly our mission for this deep dive. We are digging into the publications on MBT to explore that exact contradiction. We're going to look at the profoundly intertwined relationship between depression, attachment, separation, and loss. And more importantly, we really want to break down the mechanics of how the mind processes or, completely fails to process these really heavy emotional burdens.
Right, because understanding the mechanism is the only way to fix it.
Right. Ultimately, the goal here is to equip you, the listener, with a concrete understanding of how this cognitive tool, mentalizing, can actively interrupt that rigid neurological loop of depressive thinking.
It's fundamentally a look under the hood, so to speak, at the mechanics of human suffering and, crucially, recovery.
Yeah. And if you're listening right now, whether you work in mental health professionally or maybe you're just trying to figure out your own mind, we've all likely experienced this feeling without even realizing what it was. Because we casually throw around the word depression all the time, like, I'm depressed, my team lost the game, or this rainy weather is so depressing.
Oh, constantly. It's totally diluted the clinical meaning of the word.
Yeah, exactly. Okay, let's unpack this. Where do the texts actually draw the line? Because if we want to understand the cure being proposed here, we have to define the actual pathology first. We need to separate clinical depression from just, the everyday sadness of a Tuesday afternoon slump.
That distinction is paramount. And the authors of the clinical framework are incredibly precise about it in the publications on MBT. Everyday sadness is it's highly reactive and usually fleeting.
Like dropping your lunch on the sidewalk.
Right, exactly. You spill your coffee or you get a frustrating email from your boss and you feel a dip in your mood. But the neurochemical shift there is brief. Your body returns to baseline. But in the context of the publications on MBT, depression is framed as this rigid, prolonged state. And here is the key part. They don't just link it to general, vague sadness. They anchor it directly and almost exclusively to separation anxiety.
Okay, wait, I have to stop you there and push back on that categorization a little bit. Because when we talk about separation anxiety, the universal image that pops into my head is like a toddler clinging to their parent's leg at daycare.
Sure, the classic meltdown when mom leaves.
Exactly. Absolutely losing their mind because mom is walking out the door.
Yeah.
So it sounds highly reductive, honestly, to take the complex, agonizing reality of adult clinical depression and just boil it down to an adult version of a toddler missing their mom.
I get that. It definitely sounds reductive until you actually look at the evolutionary biology behind it, because that underlying survival mechanism, it doesn't just magically disappear when we turn 18. It doesn't evaporate. It just maps onto more complex adult social structures.
Okay, so how does that work in an adult brain?
Well, if we look at something like social baseline theory in psychology, human beings are profoundly social primates. For hundreds of thousands of years, our physical survival depended entirely on our proximity to our tribe.
Right. There was no surviving on your own.
None at all. If you were separated from your protective bonds, your caloric expenditure went up instantly, your vulnerability to predators skyrocketed, and frankly, you likely died.
So the brain evolved an alarm system to prevent that.
A deeply, deeply aggressive one, yeah. When a bond is threatened, the amygdala, which is the brain's primary threat detection center, it floods the nervous system with cortisol and adrenaline. And the thing is, the amygdala doesn't know you are an adult in the 21st century living in a secure apartment. It thinks you are alone on the savannah about to be eaten.
Wow. Okay, so it's a literal survival panic.
Exactly. The texts make it explicitly clear that depression is inextricably linked to this fundamental primal terror of separation. And they define loss in a way that totally bypasses our modern logical thinking. It is not just the death of a loved one.
Right. The research highlights triggers that we actively celebrate in modern society. like moving to a new place, leaving a job. It even lists losing one's place within a specific social hierarchy or community.
Because to the nervous system, a severance is a severance. It doesn't care about your salary bump. When you leave a job, even for a much better one, you are abruptly losing a community of coworkers. You're losing a highly structured daily role and a predictable social environment. You are severing a massive web of attachments.
So there's a disconnect between what we think is happening and what our body feels is happening.
A huge disconnect. The conscious mind is saying, this is a great career move, I should be happy. But the unconscious survival hardware is screaming, we have been separated from the tribe. Initiate the emergency separation distress protocol immediately.
But wait, if every single time we move or change jobs or go through just a standard run-of-the-mill breakup, our brain initiates an emergency survival protocol, wouldn't every single human being on Earth be in a state of chronic, debilitating depression at all times?
Well, that's where we have to look at how different brains resolve that protocol.
Right, because there has to be a physiological difference between the ubiquitous, universal human experience of losing something and an actual clinical depressive episode.
It seems like, well, it makes me think of the difference between a normal physical wound and a severe infection.
Oh, that's a really good way to frame it.
Yeah, like if I slice my hand open while cooking, my immune system immediately mounts a response. It bleeds, it gets inflamed, it eventually forms a scab, and that is painful, obviously, but it is a highly functional, necessary healing process. Depression seems to be what happens when that exact same immune response just goes haywire, starts attacking the healthy tissue, and the wound completely refuses to close.
That immunological comparison actually tracks perfectly with the clinical data. It's spot on. The publications on MBT emphasize that humans react wildly differently to a loss experience. They define the initial, highly painful period of loss as a mourning reaction.
So that's the inflammation and the scabbing in my anatomy.
Yeah.
Exactly. During that mourning reaction, your brain is actively withdrawing energy from the outside world, so it can focus entirely on processing the severed bond. You want to stay in bed, you don't want to see friends. It is agonizing, but it is biologically purposeful. You are recalibrating.
So when does it become clinical depression?
The threshold is crossed when this mourning reaction fails to resolve itself and just persists indefinitely. It lasts for weeks, months, sometimes years. That chronic, unhealing infection is what the framework classifies as depression.
Wow. So if you're listening to this right now, think about the times you felt this deep, inexplicable emptiness after a seemingly positive life transition, like maybe graduating college or moving into a better apartment. Society tells us to throw a party and celebrate, but internally, you just feel this heavy, hollow dread.
The people feel so guilty about that dread.
They really do. We rarely give ourselves permission to recognize that feeling as legitimate separation anxiety. We just think we're broken. But actually, the brain is mourning the sudden loss of an established environment. It's doing exactly what it evolved to do.
Right. But this raises a really important question for the clinical framework, because if mourning is a natural, necessary process for everyone, why does that process spontaneously corrupt in some people?
Yeah, why do some people process a breakup, cry for a few weeks, and then move on, while others spiral into a multi-year depressive episode characterized by, intense gloominess, crushing pessimism, and just complete and total collapse of their self-esteem?
What is the catalyst for the infection, basically?
Exactly. What turns the mourning into depression?
Well, the clinical texts point directly to the compounding nature of early trauma. They explicitly state that if an individual suffered a severe loss early in their development, and crucially, if they were not supported or caught by their environment during that loss, their vulnerability to chronic depression later in life is exponentially higher.
Okay, so it's not just the occurrence of the bad event itself. It's the isolation during the bad event.
Exactly that distinction. It is so vital. When a young child experiences a severe loss, say, the death of a parent, or even chronic emotional neglect from a caregiver, their prefrontal cortex is simply not developed enough to contextualize that pain logically.
They can't rationalize it.
They can't. They biologically require a caregiver's mature nervous system to help co-regulate their own panic. If that caregiver is absent, or if they are the source of the trauma, the child's HPA axis, which is the system that controls our physical reaction to stress, gets chronically flooded with stress hormones.
It just stays stuck in the on position.
Yes, and because of that, the brain literally structuralizes a core belief. It hardwires the idea that bonds are fragile, and when they break, the resulting pain is lethal, and I will be entirely alone to deal with it.
Here's where it gets really interesting. Because the publications on MBT, they don't just say that past trauma makes you emotionally fragile in some vague poetic way. They describe this mechanical, almost terrifying neurological efficiency to it. The texts state that repeated depressions create an automatic reaction that activates faster and faster each time.
Yes, it is a well-documented process that neuroscientists refer to as long-term potentiation.
Right. The old saying, neurons that fire together wire together.
Precisely. Every single time an individual spirals into that deep gloominess and low self-esteem, the synaptic pathways facilitating those specific dark thoughts and feelings become thicker, faster, and more insulated.
So instead of a slow, gradual descent into sadness, the brain essentially builds a high-speed shortcut straight to the bottom.
It does.
It actually reminds me of a corrupted, predictive text algorithm on a smartphone. Usually you type a letter and the phone guesses the next word based on common everyday usage. But if you have an algorithm that has been heavily trained on catastrophic language, the moment you type the letter I, it autofills to I am completely worthless and alone.
That is a fantastic analogy.
Right. It doesn't wait for the context of the sentence. It doesn't wait to see what you were actually going to type. It just jumps straight to the absolute worst-case scenario because that's the neural pathway with the least resistance. It's the widest highway in the brain.
That algorithmic model is incredibly accurate to the neurobiology here because the brain is ultimately just a prediction machine. It is constantly trying to save metabolic energy by anticipating what will happen next based on historical data.
So it's trying to be helpful in a weird way.
It thinks it's keeping you safe by preparing you for the worst. If someone with that early, unsupported trauma faces a minor setback at work, say, a manager gives them a slightly critical piece of feedback on a report, their brain doesn't process it calmly as standard work feedback.
What does the brain do instead?
The amygdala recognizes a faint, microscopic signature of social rejection in that feedback. And because the neural pathways for depression are so heavily reinforced from childhood, the brain autofills the catastrophe. It instantly shunts the person's entire neurochemical state into severe gloominess as a preemptive defense mechanism.
The speed of that is what makes it so incredibly insidious. Because to a colleague watching this happen in the office, the reaction seems completely absurd. They're thinking, I just told them to fix a typo on slide 4. Why are they staring at the wall looking completely devastated?
Right, the colleague is baffled.
Yeah, but the colleague doesn't see the algorithm firing. They don't see that the person's brain just bypassed logic entirely and dropped them into a severe chemical state of mourning over a typo.
And for the person actually experiencing it, the descent feels entirely involuntary. Because neurochemically, it is. The emotional state crashes down on them before their conscious mind has even registered the trigger. You are fighting an entrenched neurological reflex, not making a conscious choice to be sad.
Which brings us to a massive glaring paradox in the treatment model we're discussing today. Because if a patient is experiencing a lightning-fast, highly physical neurological reflex that drops them into total despair, well, the most logical response in modern medicine is to introduce a chemical blocker. Right?
That is the standard psychiatric protocol, yes.
You use medication to sever the reflex arc. But the publications on MBT take a highly controversial stance here. They actually advocate for taking the patient off the medication during this therapy. Why on earth would a therapeutic framework intentionally remove the exact chemical barrier that is keeping a patient's head above water?
I know, it sounds totally counterproductive at first glance. It is a stance that requires a lot of context to truly understand. Particularly because MBT mentalization-based treatment is very often utilized for patients exhibiting borderline personality characteristics.
Okay, let's define that briefly for the listener, just so we aren't throwing clinical jargon around without context. What do we mean by borderline characteristics in this specific framework?
Certainly. Borderline personality characteristics generally involve severe emotional dysregulation, an intense, often overwhelming fear of abandonment, and highly unstable interpersonal relationships.
So their alarm system is exceptionally sensitive.
Exceptionally. For these individuals, that predictive text of catastrophic loss we talked about, it is firing almost constantly. Every interaction feels like a potential abandonment. So the texts readily acknowledge that in severe cases, antidepressants and mood stabilizers are standard practice, and they are often entirely necessary for basic survival.
Right. They effectively reduce that crushing anxiety and dampen the extreme volatile peaks of those feelings. They turn down the volume on the panic alarm so the person can just, function in society, go to work, buy groceries.
Exactly. They are vital stabilizers. But what's fascinating here is the trade-off. The medications do not selectively target only the bad feelings. We don't have drugs that are that precise yet. Instead, they create a generalized emotional flattening across the board.
Everything gets muted.
Everything. And the core philosophy of mentalization-based treatment relies entirely on the patient's ability to access, feel, and then actively examine their raw emotional states. The texts argue that you cannot truly resolve the underlying trauma if your access to it is chemically muted.
It's like trying to fix a car engine while wearing oven mitts.
Yes. It is beneficial to phase out or stop medication during the treatment because feeling the actual emotion is the fundamental prerequisite for mentalizing it.
I understand the theory, I really do. But in practice, that sounds incredibly dangerous. I mean, it makes me think of putting someone in a heavy-duty atmospheric diving suit. If they are dropped to the bottom of the ocean, that suit is literally the only thing keeping the immense pressure of the water from crushing them instantly.
It's keeping them alive.
Right. Survival is the only metric that matters at the bottom of the ocean. But if the ultimate goal of the therapy is to teach the person how to swim, how to read the currents, how to build their own lung capacity, well, they cannot do that inside the rigid suit. They are safe in there, sure, but they are completely insulated from the reality of the water.
They can't feel the environment.
Exactly. They can't feel the drag of the water. They can't feel the temperature. To actually learn to survive on their own 2 feet or own 2 fins, I guess eventually, they have to take the suit off.
The diving suit is the perfect mechanical representation of the clinical dilemma here, because if the medication is constantly blunting the separation anxiety, the therapy remains entirely intellectual.
It's just an academic exercise.
Exactly. The patient might be sitting in the chair able to logically say, yes, I understand I have abandonment issues from my childhood, but they aren't actually feeling the visceral terror of the abandonment in the room. And without the physical sensation of the emotion, you cannot rewire the automatic reflex.
The reflex just hides.
It simply lies dormant under the chemical blanket, just waiting to reactivate the exact moment the medication is eventually withdrawn. You haven't cured the infection, you've just taken a lot of painkillers.
We need to be incredibly careful here, though. I want to make this crystal clear to anyone listening. We are not telling anyone to go flush their antidepressants down the toilet.
Oh, absolutely not. Please do not do that.
The texts are completely unambiguous about the safety protocols here. They state explicitly that phasing out medication is a collaborative process done strictly in consultation with a medical team, and only, and I'm quoting directly here, when the time is ripe.
Yes, that guardrail is the difference between a therapeutic breakthrough and an absolute clinical disaster. You do not crack open the diving suit while the patient is still sitting at the bottom of the Marianas Trench.
That would be lethal.
It would. You do it when they have been slowly, carefully brought up to shallower waters. You wait until a really strong therapeutic alliance is built between the patient and the therapist. You wait until the patient has learned basic distress tolerance skills. And then, very slowly, you reduce the pressure. It is a highly calculated risk designed to grant the emotional access required for genuine, long-term neural rewiring.
Okay, so let's look at what actually happens when the suit finally comes off. The medication is titrated down, the emotional flattening evaporates. Suddenly, the patient is fully exposed to their own internal cognitive environment without any chemical buffer whatsoever. The publications on MBT describe what they call depressive thinking. What does that actually look like when it's running raw and unfiltered in the patient's mind?
Once the chemical buffer is removed, the sheer brutal force of that automatic predictive algorithm becomes fully apparent. The texts note that these depressive thought patterns occur so frequently and with such intensity that the individual actually ceases to recognize them as symptoms of an illness.
They just think it's the truth.
They do. It simply becomes the default operating system of their mind. The research provides 3 specific examples of these deeply entrenched thoughts that come up repeatedly in session 11. It will never be okay again, it is all my fault, and I can't do anything.
Wow. I mean, you look at those statements. Those aren't just sad thoughts. Those are absolute totalitarian declarations of reality.
They leave no room for debate.
None. Like, it will never be okay again. Completely eradicates the concept of time and change. It implies a permanent state of suffering. It is all my fault. Absorbs the blame for the entire universe. There's no nuance there. And I can't do anything is the ultimate expression of learned helplessness. It literally paralyzes the motor system.
And they are relentless. They play on a loop.
What I find most terrifying about this is your point about the operating system, the invisible nature of the symptom. Because, when you have a broken arm, The pain clearly tells you, hey, my arm is broken, something is wrong with my arm. But when you have depression, the disease corrupts the very instrument you use to evaluate reality.
The brain itself is compromised.
Yeah, it's like a pilot flying a plane in a massive storm.
Yeah.
If the altitude gauge is broken and showing that the plane is plummeting towards the ground, the pilot is going to panic and pull up as hard as they can, even if they are actually flying perfectly level.
Right, because they trust the gauge.
Exactly. The pilot doesn't know the instrument is lying. To the depressed mind, the thought, it will never be okay again, doesn't register as a symptom of a mood disorder. It registers as an empirical, universally observable fact. It's the gauge telling them they are crashing.
You've hit on the exact cognitive trap that makes depression so fiercely resilient to treatment. The neurobiology of gloominess literally hijacks the prefrontal cortex, which is the area of the brain responsible for objective reasoning and reality testing.
So the logic center goes offline.
Completely. When the amygdala is hyperactive and sounding the separation alarm, it actively downregulates the prefrontal cortex. You temporarily lose the neurological hardware required to step back and say, wait, is this instrument panel accurate? Is this thought actually true?
But the authors of the MBT texts do something very unexpected here, which I found fascinating. Instead of telling the patient, your instrument panel is broken, your thoughts are totally irrational, you need to ignore them, which is what a lot of us try to do when friends are sad, they actually validate the broken gauge. The text says these thoughts are often the result of having experienced many traumatic events and calls them, quote, understandable.
It is a radically compassionate approach, but more importantly, it is structurally necessary for the therapy to work.
How so?
Well, think about it. If a patient grew up in a chaotic environment where every single attachment figure eventually abandoned them or hurt them, it is entirely scientifically understandable that their predictive algorithm spits out, it will never be okay again.
It's just running the math on their past.
Exactly. It is a highly logical deduction based on a lifetime of corrupted data. If a therapist comes in and immediately invalidates that thought, calling it irrational, it just creates more alienation. The patient feels misunderstood, the separation anxiety spikes again, and the protective walls go right back up.
Right, because you're telling them their lived experience isn't real. But there is a massive however in the research right after that validation.
A critical one, yes. The texts pivot immediately, they say. While the thoughts are understandable given your history, they are so firm, so incredibly rigid, that they actually become the very mechanism maintaining the depression in the present.
It's a feedback loop.
A perfect one. The physical gloominess generates the catastrophic thought, and then believing the catastrophic thought reinforces the physical gloominess. It is a perfectly sealed echo chamber. And because the individual is so physically exhausted by the gloominess, they completely lack the cognitive energy to interrogate the thoughts. They just accept them.
So, if the disease actively disables the part of your brain required to fight the disease, how do you fight it? I mean, if you don't know the instrument panel is lying to you, how do you keep the plane from crashing? This is where all the theory we've discussed so far, this separation anxiety, the corrupted predictive text, the unflattening of the emotions, it all funnels into the core intervention of the publications on MBT.
Right. If we connect this to the bigger picture, the entire goal of the program crystallizes in this one specific intervention. The texts state their primary objective with elegant simplicity. They say, in MBT, we try to help people mentalize better, and that can help them to better place question marks behind those depressive thought patterns.
So what does this all mean mechanically? We've explored the definition of mentalization in past deep dives, but how does it function as a wrench thrown into the gears of this specific, rigid depressive loop?
To mentalize is to intentionally engage the medial prefrontal cortex. It is the active, conscious practice of stepping back and observing your own mind. It's recognizing that your mental states, your thoughts, your beliefs, your feelings are merely representations of reality. They are not reality itself.
That's a huge distinction.
It's everything.
Yeah.
In the depths of a depressive spiral, a thought like, it's all my fault, is processed by the brain as a declarative statement, a solid brick wall.
It has a heavy, immovable period at the end of it. It's all my fault, period.
Precisely. Mentalizing is the cognitive mechanism of swapping that period for a question mark. By simply asking, it's all my fault, you force the brain out of the automatic amygdala-driven reflex. You force it to power up and engage those higher-order reasoning centers. You are no longer just helplessly experiencing the thought, you are observing the thought from the outside.
You are looking at the altitude gauge and suddenly wondering, when is the last time this thing was calibrated? You aren't necessarily proving the gauge wrong yet. You aren't saying it's not my fault, but you are no longer blindly obeying it as absolute truth.
And neurologically, that tiny, seemingly insignificant moment of doubt is profound. When you introduce a question mark, you literally create synaptic space. You interrupt that fire together, wire together sequence we talked about. The thought transforms from a life sentence into a working hypothesis.
And a hypothesis can be tested.
Exactly. It can be tested against evidence, it can be debated, it loses its totalitarian power.
The publications on MBT provide a very specific piece of homework for this session, and it is beautifully realistic. It asks the patient to track their depressive thoughts over the week and note how they dealt with them. And the exact phrasing is so important here. It asks, were you able to draw these thoughts or convictions somewhat into doubt? It is vital to note what the clinical text does not demand of the patient here.
Right. It's very deliberate in what it leaves out.
It doesn't ask, were you able to stop the negative thoughts entirely?
Because the researchers know that is biologically impossible. The predictive algorithm is way too fast and too deeply entrenched for that. Trying to stop an automatic thought by sheer force of will is like trying to stop a freight train by standing on the tracks and putting your hand out.
You're just going to get run over.
You are. And then it only results in the patient feeling like a failure because they couldn't stop the thought, which feeds right back into the exact depressive loop they are trying to break. I couldn't stop the thought, therefore I am worthless.
Right. And the homework also doesn't say, were you able to replace your dark thoughts with joyful, positive affirmations? It doesn't demand this sort of toxic positivity where you look in the mirror and lie to yourself. It just asks for a fraction of a percent of doubt. Just a hairline fracture in the absolute certainty of the depression.
Because that hairline fracture is the absolute essence of mentalization. You allow the thought to manifest because, let's be honest, it will manifest automatically anyway, but you revoke its authority as absolute truth. When the brain auto-fills the sentence, I can't do anything, you mentalize it.
You observe it.
Yes, you observe it and say to yourself, okay, I am currently experiencing a highly active depressive neural pathway. It's been triggered by my historical sensitivity to loss, and it is producing the sentence, I can't do anything. Is that an objective fact about my current capabilities in this room right now?
And you don't even have to have the energy to answer no right away.
You don't. Just opening the door to the mere possibility that the thought is an echo of past trauma rather than a factual assessment of the present moment begins to dismantle the echo chamber.
If you're listening to this right now, I really want to challenge you to bring this specific clinical homework into your own life this week, because you do not need a clinical diagnosis of depression to benefit from this tool. We all possess an inner critic that operates on these exact same rigid, absolute terms.
Oh, absolutely. Everyone has that predictive text.
Yeah. So sometime in the next few days, your brain is inevitably going to serve you a sentence that feels devastatingly true. Something like, I'm an imposter at my job, or my friends don't really care about me, or I'm going to totally fail this project. When that happens, I want you to visualize taking a massive red marker and drawing a huge question mark at the very end of that sentence. I'm an imposter. They don't care about me.
Just observe what happens in your body when you do that.
Exactly. Just observe how the physiological weight of the thought shifts. See if you can summon just a micro ounce of doubt regarding your brain's catastrophic prediction, because that tiny microscopic question mark is how you begin to reprogram the entire algorithm.
It really is a profound act of cognitive rebellion. And as the research strongly suggests, practicing that rebellion over and over week after week is how those thick, heavy neural pathways of despair slowly weaken from disuse. And eventually, new, more flexible, healthier pathways begin to form.
It completely reclaims the entire experience of the illness. To view depression not as a personal failure or some random meaningless chemical glitch, but as a hypervigilant, deeply misguided survival mechanism that is just desperately trying to protect us from the agonizing pain of separation. I mean, it changes everything about how we approach healing.
It replaces self-condemnation with curiosity. And that curiosity is the absolute bedrock of mentalization. Before we conclude today, I want to leave you with a final, lingering thought to explore on your own, synthesizing the core principles we've extracted from the clinical texts.
Let's hear it.
If our depressive spirals are fundamentally rooted in the primal terror of separation and loss, and if our brains are ruthlessly efficient at using past traumas as templates to judge present events, ask yourself this. The next time you feel an overwhelming, paralyzing sense of doom over a minor slight, a delayed text message, or a small professional setback, are you truly reacting to the situation in front of you? Or are you reacting to the echo of someone who left you unsupported a very, very long time ago?
Wow, a profound question to end on. This brings us to the end of all 11 sessions of the MBT program. In the next episode, we will offer a unique and personal insight into a one-on-one therapy session with the title, Behind Closed Doors. Thank you for listening, and don't forget to follow us to stay up to date with our latest episodes.